Hey everybody, I hope life's treating you well. Welcome back. Hope you're enjoying the cool weather. I just got done emailing or responding to all the emails in my inbox. So if you were reaching out to me for any reason, you've got a response. I also posted a pretty long thread in the Teams chat because some of the questions that were being asked in the email seemed like they'd be beneficial for everybody. So go check that out. Please read to the end because there's something there that I really need every one of you to pay attention to. And I don't need every one of you to reply to, but I may need you, the person watching this right now, to reply to it. So go into Teams and check that email out. Or not email, but thread. I think that's all of the updates I wanted to give you on the class itself, on the class mechanics. I mean, there's other things I wanted to say, but they're in those uh, posts in Teams. Uh, I should give you an update on my mother's situation because it's totally relevant to this class. And there are a lot of classes where anecdotes don't really help you learn the material, but ethics is one of those things where you would think, well, principles are really what matters. You don't need a lot of anecdotal, stories or whatever to understand medical ethics. You just need to know right from wrong. But really, what helps in making these decisions, making medical ethical decisions or approaching medical ethical cases, is having seen a lot of individual cases and using those to reason by example. So anecdotes are really helpful. That's why we do case studies. So this is just sort of a live case study that happens to be going on right now. So my mother went in. She had a lot of stomach pain and a mass growing in her stomach. The mass turned out to be benign, thankfully, um, but they had to do some pretty invasive surgeries, one of which involved taking out a section of her bowels, and she's mostly recovering okay. But her situation is complicated, as or most situations are complicated, right? Her situation is complicated in the following way: she is a she experiences chronic pain in her daily life. She has for like 25 years experienced difficult to diagnose or understand chronic bodily pain. The only uh, effective treatment for people who have this is often opioids. And so for a long time, she's been on varying levels of narcotics, mostly morphine. Sorry, my allergies are coming. But uh, medical treatment is super complicated and details often don't get communicated. So when you go into the hospital, if you're on a certain regimen of medications, they need to be administering those same medications to you, right? My mother goes in to the hospital and she has a surgery and they give her a certain amount of pain medication, but they also need to understand that she's on a certain amount of pain medication daily already, so her tolerance is higher. So the standard amount of um, pain relief medication that she should be getting isn't going to be enough. She needs to get higher than the normal level to compensate for her higher tolerance. This is it's Maggie. Um, but this wasn't communicated to her doctors. Not sure whose fault that is. It doesn't really matter. Fault isn't the important thing. The important thing is care, making sure a person gets the treatment that they need. So I'm the person who's continuously communicating with doctors on her behalf because she's, for lots of various reasons, she's pretty bad at advocating for her own best interest with doctors. She has a lot of anxiety about communicating with them. Um, and so it just tends to fall on me to every day make sure that treatment is being managed properly and that the doctors understand what her situation is from her own perspective. So eventually this gets communicated to the doctors, which explains why she's in such extraordinary discomfort after her surgery because she's only getting about the normal level of pain medication that you should take during the day, uh, not any extra to compensate for the pain of having her intestines removed, basically, or sections of them removed. So she's in a lot of pain. This gets communicated. They change her degree of palliative care, which is what we call just relief of pain in the medical world, and she's fine. She's doing great. But because she has a high tolerance now, she has to have a pretty alarmingly high amount of narcotic medication dripping into her veins constantly in order to keep her out of really serious pain. And I mean, you can imagine if I took a knife and cut your bowels open and pulled your intestines out and cut them and sewed them all back together and did all sorts of weird stuff in there, afterward you'd have a lot of nerve endings that had been exposed and messed with and inflamed, and it's going to be seriously uncomfortable, enough to the point that you can't just grit your teeth and bear it. It actually is sort of maddening. You can't focus on anything. You're just constantly thinking about your own pain. So she's now on a higher level of medication. This is what would happen for any person who takes pain medication on the reg, which is it's like 3% of the American population or something. It's a lot of people. So now she's on a pretty high dosage of a pain medication called Dilaudid, which is like what Michael Jackson took to go to sleep. It's like a super serious pain medication. And they've got her pain under control, and she's healing, right? But they're trying to get her to the point that they can release her from the hospital. I mean, ideally, you want the person to go home and be okay, and not have to just sit in the hospital all the time. So, but in order to do that, you have to take their pain medication down to a level where when you release them, they won't just immediately start going into withdrawal. And withdrawal from opiates is a uniquely hellish experience. So what they have to do is they have to start bringing her pain medication down slowly as she starts to heal. And that will be uncomfortable for her, but there's no better option than to do that, right? I mean, they can do it more or less slowly, but they're going to have to, as she heals, bring her pain medication down to the point where they can just release her out into the wild with a few tablets that she can take, but nothing like the constant drip of Dilaudid that goes into her veins. Sorry. My BFF is having relationship problems. But, so, this is what they do. The doctor, there's a specific doctor who's in control of the pain treatment of this entire floor of people. She's on an oncology floor because she had a form of cancer, not a particularly malignant one, but a form of cancer in her stomach. So she's on the oncology floor with a lot of other cancer patients, and there's a doctor whose sole job it is to go around and measure the pain levels of every person and adjust their pain medication accordingly. So her doctor goes in and has a talk with her and comes out and tells the nurses, okay, we're going to take her down from, she's getting 2 milligrams of Dilaudid every 4 hours. We're going to take her down to 1 milligram of Dilaudid every 3 hours. So she was getting a half a milligram every hour. Now she's going to be getting a third of a milligram every hour. So that's a significant but not huge change in the amount of pain medication she's getting. But he doesn't tell her this. He just makes this decision, which is a valid medical decision to make, but it's not communicated to her. So the next day when I'm talking to her, her complaint is that she feels way worse than she did the day before. And because she has lots of anxiety issues, she, in her head, is spiraling into all these thoughts about why she might be feeling worse. Some of those thoughts have to do with something might have gone wrong in her body, and it's making her sicker, or some of the thoughts have to do with maybe my nurses aren't actually taking good care of me. She even gets to this point where she's wondering, maybe I've somehow made my nurses angry and they're secretly depriving me of pain medication in order to retaliate against me because I've been too needy of a patient or something. I mean, she's psychologically vulnerable. And all of this happened simply because her doctor did not communicate to her, I'm bringing your pain level down. The reason the doctor didn't do that, I didn't have to talk to him to know this, though I did talk to him about this, because I had to become an investigator and find out why she feels worse and what has happened. All this happened because I had to call 3 or 4 different people and bug them and annoy them by asking questions. But the reason the doctor made this decision, and this is a very common thing, is that it just seemed like the right thing to do. It's the sort of normal protocol. And when something feels like a normal protocol, you normally don't feel like you need to communicate it to a patient to get their permission or okay with it, because it's just the way things are going to go anyway. It's just part of the program. But of course, patients don't know what the program is in hospitals. Um, so it has this really, for some people, very negative effect. My mother is one of the people that it'll have an acutely negative effect on. Whereas most people would simply say, I feel a bit worse than I did yesterday, but I'm not too worried about it. Maybe ask their doctor what the deal is, and the doctor would explain to them that they're taking the pain medication down. Some doctors, though, don't want to tell patients that they're going to take their pain medication down, precisely because they're worried that the patients will get a lot of anxiety about experiencing more pain, and they've already been through a painful experience and sometimes a traumatic experience. Surgery can be traumatic. And that weighed in, I think, subconsciously to this doctor's not even decision, but his automatic way of doing his job, where he didn't inform his patient he was going to change their medication. Now, we've talked about informed consent before, and I can guarantee you that this sort of situation that my mother is facing is totally common. I mean, this sorts of things like this happen all the time. But on the face of it, it seems, or it would seem to most people once you explain to them informed consent, that taking a person's pain medication away from them, taking some of it away, is the sort of medical decision, treatment decision that a patient needs to be aware of, and they need to have some say in saying okay to. I mean, that that's the standard for medical decisions. Why shouldn't it be that way for pain medication or pain treatment? Well, the reason doctors don't tend to automatically think of pain treatment in these terms the way they do with other medical decisions is because there's this attitude that it just sort of evolves in the mind of most medical workers, that pain is not a real medical problem. It's just a side effect of a real medical problem that needs to be managed as a sort of favor to the patient. Now, that pain management is often seen as a sort of luxury, whereas actually treating the root cause of the pain is seen as the real medical issue or medical work that you owe a patient. The degree to which doctors take people's pain seriously, as we've seen in some of the readings, often also hinges on the doctor's perception of the patient's race or age or gender. And that's also hugely problematic. Doctors tend to perceive black people as experiencing less pain than white people do, and tend to experience men as experiencing less pain than or more pain than women, which is just not the case. There's no reason to think that men or women have higher or lower tolerances of pain in general, or that black or white people have lower or higher tolerances of pain. There's no medical reason to think that. It's just a subconscious sort of perception on the part of doctors. So, the question I would ask you is, in treating a patient's pain, how do you go about making that decision? On the one hand, you probably do have some inclination to say, well, informed consent is important here, and a person needs to be informed that their pain care is going to be slowly taken away, and that they're going to experience more discomfort so that they can brace themselves for it. But you might, on the other hand, say, well, you don't want to freak patients out. It might be better if they didn't know, because if you get them thinking too much about their pain, that can make their pain worse just by getting them to focus on it. So, what do you think? Don't don't write and say, here's what I think they should have done with your mother. But if you want to journal about this, the question is, how do you balance those two considerations? Informed consent on the one hand, and concern for a patient's psychological well-being on the other. If you think that telling them something is going to psychologically damage them or put them in a negative psychological state, right? There's no third option to keep them on the same amount of pain medication because you just don't want people to be permanently hospitalized simply because you've gotten them reliant on a certain level of opioids or something. You don't want to take them off, right? You have to take patients off of their pain medicine, and in some cases, pain medicine can actually slow down the healing process. It can also raise the rate of injuries or that you do to yourself because if you're not aware that um, an area inside you is sensitive, you might do things that disrupt it or harm it more easily than you would if you were constantly aware of the sensitivity or the wound that's healing there. So, how do you balance these considerations? It's not so easy to say, well, just you should give people informed consent, right? I mean, like we learn these principles, but in practice, it's just not that easy. Um, yeah, so that's a case I want you to think about. The topics that you've read about between this and the last lecture are things we've talked a great deal about already, and we've just read more detailed work on them. So, euthanasia, the readings talked about the distinction between active and passive, and voluntary and involuntary euthanasia, and tried to map some ethical distinctions onto those. And then we've read about confronting death in the Being Mortal book and in the piece from Harper's, which I think is an especially moving piece, but where the physician contemplates his own death. There's not a lot that I want to add to those because we've thought them through fairly well. But one question I want to pose to you is this. As medical care gets better and better, death sort of recedes from us further and further into the future, right? The whole point of medical care is to keep death and injury away from us. Currently, the what do we call the mortality rate, or not mortality rate, but the life expectancy of Americans for the first time in like all of measurable history has declined slightly, and most of that is actually due to the opioid epidemic. But if you take away causes like opiate addictions, the life expectancy of people in the developed world is going up, 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 up. Right? It went from the 60s into the 70s now, and it's I think women have crossed over into 81 years as average life expectancy if you don't do certain things like smoke heavily, not born with diabetes or whatever. So it's interesting to note that we're living longer. But what's more interesting to note is the rate at which life expectancy is changing. So it sort of slowly increased over time, starting with the invention of underwear, which staves off a lot of infection. And it bumped up pretty quickly when we invented the polio vaccine and when we learned about like germs and things. Life expectancy goes up pretty quickly as we make those discoveries. So there's a speed at which life expectancy is increasing. And to compound it, the rate at which life expectancy is increasing is itself increasing. That is to say, the rate at which we're gaining more years is speeding up. And we can say, well, if we keep accelerating at this level, accelerating the rate increase in life expectancy, we can look into the future and say, well, what will life expectancy be in 50 years or so? Within your lifetime, though, so pause. The way you could express that rate of change of life expectancy is how many extra days of life expectancy we gain per year. Right? So now life expectancy is increasing at like every year it goes up by maybe a month or something, we'll say. But if we look into the future, within your lifetime and mine, the rate of change, the rate of increased life expectancy will actually be more than 1 year per year. I think around 2035, we get to life expectancy increasing at a rate of more than a year per year. That means that life expectancy is receding, or death is sort of receding from us in the future. That's a qualitatively new phase of human existence, humans' relationship to their own mortality. Right? It used to be that every person was headed toward their own death. But if it becomes known publicly that life expectancy is increasing at more than a year per year, more than a second per second, that you're actually gaining more life every second at the statistical level, our attitude towards death changes because you're pointed in the same direction as death, but death is like speeding away from you now because of our technological achievements. And understanding death in that way might radically change the way people think about death as an inevitability in their life. It might change the degree of resentment people allow themselves to feel towards the idea of their own death or the deaths of others. So when we talk about voluntary euthanasia, we say, well, look, one of the conditions that we think would justify voluntary euthanasia is a person saying, or coming rightly to the conclusion that there's just no more good life left to live for me. I've got 6 months and it's going to be hellish cancer, pain, and I can't do anything fun or enjoyable in those 6 months. So there's no point in just slogging through them on principle. So let's just go ahead and call it quits now. That seems like a super reasonable way to decide how to end your life. But if the rate of medical breakthroughs becomes so great that the foreseeable future, even within a year, might bring changes, it also starts to raise a sort of level of skepticism about whether you can ever know if your medical condition is, so bad that you don't have any hope. I mean, in cases where you just have a month or two or a year, certainly you can bank on that being pretty accurate most of the time. But there are other conditions where medical change might actually happen within the period of sickness that you have before you. So how do those changes affect your attitude towards your own life or death? If you know that the average is getting bigger at such an alarming rate that, death seems much less imminent, much less necessarily imminent. How does that change the way we think about when to end our lives or why we should end our lives? And another question I want to ask is, how do you expect your life will end? When you're thinking about all these arrays of different ways that people's lives end, or people make the choice about whether their life should end, or whether we make it legal for people to make those choices, you are going to die. I think I'm going to die at some point. But how do you think it will go? And how does that affect your own contemplation of the death of other people? I think it matters a lot if you have a conception of your own death when you approach thinking about other people's deaths. Because if you're in this state where death seems like sort of this remote, abstract, vague possibility, like one day it'll happen, but you don't really think about it, then encountering other people whose death is imminent is a very different experience, and you have a very different attitude towards it than if you are in a mental state where you have accepted your own death. I've often wondered if there's some duty that medical workers, doctors, and nurses have to go through the experience of psychologically accepting the fact of their own imminent death, because it would make them more understanding of this mental state experience of people they're working with, working on, working for, who have suddenly come to that realization themselves. I can personally confirm that I have accepted the fact of my own death. I am not particularly happy about it, but I've on in real occasions, in real conscious moments in my life, more than once have genuinely believed this is the moment when I'm going to die. I'm glad I was wrong about those moments. They weren't suicide moments. They were times when something was happening and I thought, here it is. This is the moment. And it was a surprisingly peaceful experience, which is nice and reassuring. And it's also reassuring to look back on that and know that I can handle that moment, that I'm not going to just spend my last moment freaking out or whatever. And I also think that it has really, really changed how I talk to you or talk to patients or doctors about the mortality of their patients or themselves or whoever, because I understand that there's this moment of reckoning that dying people have to come through, and most of us have not come through that moment. Most of us only go through that moment, like I did, when you're sort of forced to. But I think through contemplation and meditation on the fact of death, you can also come to that state. And there's a Catholic tradition called the memento mori, where you constantly meditate on the fact that you are mortal and that one day you will die, and that is supposed to sort of reinvigorate your love for life and your love for other people and your commitment to spend the time that you have wisely and morally. But we don't do that now, probably because we're less religious, but also because we have a different attitude towards death. I mean, we sort of already have this resentment of death, or at least this sort of subconscious denial of it. But back to the question I was asking about the extension of life expectancy, that fact might give us some rational, not just a subconscious denial, but a rational reason to sort of deny or resent or back away from the idea that we need to just accept death as an inevitability. But whether we do or whether we don't, I think will have radical implications for how you just talk to a patient who's dying, or how you think about the treatment of a person whose life is at risk. So I don't know what the upshot about that is, but it's at least worth meditating on and thinking about in your journals, which are, again, the exercise that I think is most useful in this class. So I hope that you've been doing them. I hope you haven't been burdened by anxiety about doing them. That's not the point. I wish somehow I could just magically remove the anxiety of performance in school, so that you could just do the exercises that are beneficial and get what's good out of them. But I can't do that. But to the extent that you can, let that anxiety go and just engage with material in your journals. Think out loud on the page. That's the best thing you can do for yourself for this course. I hope that you're all staying safe and healthy, and I know a lot of you are looking forward to going home for Thanksgiving. I am totally ambivalent about what to think or feel about Thanksgiving. I mean, I know a lot of people need to see their family. I also know that big gatherings right now are a bad idea. I mean, it would be if you can psychologically bear it, I think it's best not to meet with a lot of people over Thanksgiving. Limit yourself to a small group. We have 5 people who are going to be at Thanksgiving this year in our house, and they're people that we all see with regularity and are already part of our limited bubble of contact that we have. So the point is, extending your bubble of contact very widely over Thanksgiving creates an exponentially greater amount of risk. So to the extent that you can, keep yourself and others safe. Eat outside if you can. If you gotta sit in the car with people during a ride with windows down. Air circulation helps prevent transmittal of the virus. And just be smart. Wash your fucking hands. But I hope that you still do find some warmth and comfort over the holiday, and some rest from what I know is a very hectic semester for everybody, and I don't think next semester is going to be much easier. So maybe I shouldn't have said that, but maybe it'll help you brace for next semester. Anyway, we're at 32 minutes. I've jabbered enough. I'm going to go make dinner for my housemates, and then I'm going to go to sleep. I hope you have a good night and a good weekend. Later.